Now we're going to talk about distributive shock states, and there are three types in this category: septic, neurogenic, and anaphylactic. And in distributive shock, we can have shock caused by the loss of sympathetic tone, dilation of blood vessels, pooling of blood in the venous and capillary beds, increased blood vessel permeability. So start thinking about ARDS that we talked about in respiratory. Release of biochemical mediators, and all of these factors can reduce the mean arterial pressure. So the first type is distributive shock is septic. Very, very common, something that you're going to see sepsis bundles and sepsis protocols posted all over your units. What's happening with sepsis is that you have an underlying infection that leads to a SIRS response, the systemic inflammatory response syndrome, and that causes capillary leak. So we have a slight drop, in the circulating blood volume, relative hypovolemia, they sometimes refer to that as, not as massive as you see with hypovolemic shock, but enough to impact the delivery of oxygenated blood to your cells, tissues, and organs. There are two phases of septic shock: an early hyperdynamic phase when the patient starts to go into septic shock. You may hear that referred to as warm shock, and that's where there's increased cardiac output and vasodilation and the skin is pink and warm. Then when they deteriorate and they go completely into septic shock, that is the hypodynamic phase. You may also hear that as the cold shock. And that's where the blood pressure drops, the cardiac output drops, the pulse pressure drops. They start developing DIC and ARDS. So there is a table in Chapter 54 that gives you the etiology of septic shock. Any kind of infection that a patient is unable to fight off because of predisposing conditions. Some of those predisposing conditions can be malnutrition, large wounds, deep decubiti, patients who are immunosuppressed, such as those who have malignancies or are on chemotherapy, any kind of UTIs, pancreatitis. So you've got a lot of types of things that can lead that patient to go into septic shock. And then once we get into and we identify the fact that the patient is in septic shock, we need to identify the causative organism so that we can give an organism-specific antibiotic to treat it. So with septic shock, and we have our SIRS criteria on how to identify when someone's going into that SIRS response, QSOFA. So there's all kinds of signs that you may see as you go into your units that help us to identify whether that patient's at risk, because the ideal is to nip it in the bud before they actually go into shock. So we have fluid resuscitation, a bolus, usually 30 milliliters per kilogram, to raise the mean arterial pressure, and then a rapid infusion, anywhere from 500 to 1,000 per hour. So it's a massive fluid resuscitation to bring that circulating blood volume back, because we're having all that capillary leak because of the SIRS response. We're going to give them an organism-specific antibiotic. We're going to give them a vasopressor. Norepinephrine, Levophed is the common one if the mean arterial pressure remains low. So fluid resuscitation first. If that's ineffective, then we give them the vasopressor. They're at a high risk for ARDS, so we need to have the ventilator on standby, and more likely than not, the patient is going to require mechanical ventilation with PEEP. And we are going to monitor our lactic acid levels. Remember that metabolic acidosis that occurs because of that anaerobic metabolism. So as the patient's lactic acid levels rise, we know that they're getting worse and they're going into impending shock. Our complications of septic shock are ARDS, which we talked about in respiratory, and something called DIC, which I know you've heard of in previous courses. The pathophysiology is that because of the damage to the capillary membranes, there's roughness, there's openings, there's ways that our platelets can break apart and start to form clots. So there are two phases that have different treatments, and you need to know these. Phase 1 is the early onset of DIC where there is massive clotting throughout the body because of all of this damage to the capillary membrane throughout the body. So clots are forming everywhere, and clotting factors are being used up at massive rates to do all of this clotting. So early on, if we detect that they're going into DIC and they're in that first early phase, we're going to give them anticoagulants to stop this clotting process before it gets too bad. Because what will happen is eventually they're going to run out of clotting factors. That's the phase 2 late stage of DIC. Now they can't clot at all. They've run out of clotting factors. So now they just start bleeding everywhere. They're going to have prolonged PT, PT-INRs, PTTs, fibrinogen is going to be decreased, their platelet counts are going to be decreased, they're going to be bruising and petechiae, bleeding in the brain, blood in the urine, blood in the GI tract, blood from IV puncture sites, blood from wounds. They can't clot. So now we have to give them platelets and plasma and clotting factors to help them start to clot again. So all of these are going to be, if you need to know the differences between the early phase where they're clotting all over the place and we have to give them anticoagulants, or the late phase where they can't clot anymore because they've used up all their clotting factors and they're bleeding all over the place, and now we have to give them platelets, plasma, and clotting factors. The second type of distributive shock is neurogenic. So just like cardiogenic was a failure of the heart to pump, neurogenic is a problem within the neurologic system. And because of that, we lose sympathetic tone. Remember, the sympathetic nerve impulses tell our heart to increase its rate, cause vasoconstriction, increased respiratory rate, slowed down of our GI motility. But if there's some problem that blocks those sympathetic nerve impulses, then we are not going to have that ability to compensate in that way. So we're going to end up with massive vasodilation and capillary leak and blood pooling. We're going to end up with severe bradycardia because remember, the sympathetic nerve impulses increase our heart rate. If those are blocked, we get into bradycardia, just like when we think of beta blockers that slow down our heart rate. Neurogenic shock is the only type of shock that's going to slow down your heart rate. Certain causes of neurogenic shock can be traumatic brain injuries, brain tumors, spinal cord injuries, general or spinal anesthesia, reactions to that. So once we figure out what the problem is, we need to support the patient with vasopressors to help bring their blood pressure back up. We're going to support them with medications to increase their heart rate, like atropine, which we talked about when we talked about dysrhythmias. And we need to restore sympathetic tone by reversing the anesthesia or monitoring them and decreasing the swelling when it comes to their traumatic brain injury or their brain tumor. So that is neurogenic shock, the only type of shock that has bradycardia instead of tachycardia. And then we have anaphylactic, which a lot of us are familiar with. It's a severe antigen-antibody reaction with a severe histamine release that causes damage to our capillary membranes, capillary leak, increasing edema, particularly in the airway. So our causes can be diagnostic tests, medications, other drugs, blood transfusions, allergies to foods, or insect bites or spider bites or things like that. The specific signs and symptoms with anaphylaxis are laryngeal edema, because remember we're having capillary leak, laryngeal edema, spasms of the bronchi, so bronchospasm, stridor, that tight inability to move air in and out, so it's like a whooping sound, wheezing, hives, because remember we have capillary leak, so if you ever had hives, it's a raised pink rash because the fluid has leaked into the interstitial space. Warm, moist skin. So our treatment is to figure out what caused it. We're going to give epinephrine, IV Benadryl, or other antihistamines, fluids, and prepare for intubation because this patient is going to probably go into a respiratory arrest. Remove the bee stinger if we're able to. Try to counteract whatever the poison was or the allergen was that the patient is reacting to. And the last type of shock is obstructive shock. So remember, cardiogenic is a failure of the heart itself. Obstructive shock are external factors that cause the heart to be unable to expand and contract and pump effectively. So if the heart was left to its own devices, it could pump adequately and there would be no problem. So obstructive shock is an external obstruction to the function of the heart. So things like pulmonary embolus, pulmonary hypertension, tension pneumothorax, pericarditis, pericardial effusion, mediastinal tumors, cardiac tamponade. All of these they're external problems that make it hard for the heart to pump effectively, and so our cardiac output is decreased and we have lack of oxygen getting to our periphery. So we have to treat the underlying cause. We need to put in a chest tube. We need to drain the pericardial sac. We need to treat the pulmonary embolus or the pulmonary hypertension, do an embolectomy. Whatever the reason is that's obstructing the function of the heart, we have to get rid of it. So as a wrap-up, why do we do these diagnostic tests for all types of shock? Lactate level, because that's going to tell us how severe our anaerobic metabolism is, how much better the patient is getting or how worse they're getting by their rising and falling of their lactate levels. BUN and creatinine, that's going to tell us kidney function. So if we see our patient with reduced urinary output, is it because they're compensating or is it because they're in kidney failure or going into it? So the BUN and creatinine should be normal in that compensatory phase, but it will deteriorate and get worse, indicating renal failure when that patient is not compensating anymore. Chest x-rays can tell us what types of internal damages that might be occurring that's causing perhaps a hypovolemic or obstructive shock. An echocardiogram will tell us the function of our heart. Why is this patient in cardiogenic shock? Abdominal ultrasounds, diagnostic peritoneal lavage to detect if there's any internal bleeding or damage that could be our underlying problem when it comes to our hypovolemic shock, for example. So we're going to do various diagnostic tests to diagnose what our underlying problem is and what we're going to do about it. So our nursing interventions for all types of shock maximize oxygen delivery because the underlying problem with all types of shock is not enough oxygen getting to the periphery, to our cells and organs and tissues. So think about all the ways that we're going to maximize oxygen delivery. Supplemental oxygen, ventilators, positioning the patient with the head of the bed up if they can tolerate it, because that will open up their airway. If they have cerebral edema, elevating the head will help to drain some of that fluid. But we can't put it up too high because some of these patients already have low blood pressure and they may have orthostatic drops in their blood pressure by putting the head of the bed up. Maintain adequate body temperature because our body expends a lot of energy trying to normalize our temperature. If it's too high or too low, it's expending a lot of energy, so oxygen and nutrients, and we're already depleted in oxygen and nutrients. So we need to make sure that that patient's body temperature is as normal as possible. And then nutrition. Nutrition can help to improve and help that patient heal from various types of shock. So the earlier we get enteral or parenteral nutrition going, either TPN or tube feedings, that's going to help the patient heal better and help them to better be able to compensate.